Good afternoon, everyone, and thank you for joining us today to discuss diabetes in your feet. My name is Taja Fox, and I am the Communications Officer here at the Health Council. Joining me today is Dr. Natalie Bennett of Arches Podiatry. Today, you will hear how diabetes affect your feet and what does a podiatrist do to assess and monitor a diabetic. At the end of the webinar, we will have a live Q&A session where you can get your health questions answered. Now, I'm going to welcome Dr. Bennett to start and kick off today's presentation. Dr. Bennett, you now have the floor.
Good afternoon, everyone. Good afternoon, Taja. Thanks for having me. I'm just going to get my presentation up. And oops. Okay, let me go back. Hopefully you can see my presentation. Is it up on screen? I hope so. So this is Arches Podiatry. I'm Natalie. Just wanted to present to you a little bit of information about myself. I've been here in Bermuda for almost 13 years now. I've worked at lots of different locations throughout the island, but I now have started my own practice, which is Arches. We've been operating since October last year. I currently don't have a receptionist, so just letting people know that the best way to reach out to me is via archespodiatry.com. Happy to answer any questions that way. So one of the first things I wanted to address is, what does a podiatrist really do? The top four that we have on the screen: general foot care, diabetic foot care, lower limb vascular assessment, and nail pathology and nail surgery, will all be covered in this presentation. But some of the other things that people are not aware that podiatrists do: we're quite involved in sports podiatry, so assessing, diagnosing and treating sports injuries of the foot, the ankle, the knee. We are quite often involved with some of the local sporting teams to deal with injuries to get people back on the field quickly. We also deal with pediatric foot and leg assessment. Most people think, why would we be seeing a child? Children have feet and legs too, and they get into trouble with all sorts of foot pain, knee pain, injuries, growing issues, things to do with their sports and their development. Another thing we do is Hello?
Hi, I'm so sorry to interrupt. Can you share your presentation?
I thought I was.
It is not showing on the screen.
It's not? I did say share. Okay. How are we going now?
Yes.
Are we there?
Yes. If you could start.
So sorry.
On the slide. There you go.
I'm sorry.
No, you're fine. It looks perfect. Yes.
Thank you. Okay, sorry about that. So going back to that first screen, general foot care, diabetic foot care, those top four we're going to deal with in our presentation, and the lower three, which we've just been discussing. The other aspect is diagnosing and treating pain in the lower back, hips, knees and feet. Some of the more common conditions that people are aware that we diagnose and treat would be plantar fasciitis or heel pain. It's probably a pretty common condition. Somebody has either had it or knows somebody who's had it. And Achilles tendonitis is another really common condition that we treat. Another thing that people often ask is, what's the difference between a podiatrist and a chiropodist? I probably get asked that question more than anything. A chiropodist probably does, it's an older term, it's an older qualification, and it probably entailed more just the general foot care, general nail pathology. But with podiatry, we delve a little bit deeper, so things like vascular assessments, nail surgery, and then going into the sports podiatry and the lower leg and foot assessment. So that's the big difference there. Another question we get asked often is, are you a doctor? I'm like, no, we're not a doctor, we're a podiatrist. The same way your dentist is your dentist and your optometrist is your optometrist, we're a podiatrist. There is no doctor's referral required to come and see us. You can self-refer, you can call up, you can ask questions on the phone to determine whether a podiatry assessment is going to be appropriate for you and your needs. So diving into diabetes. Currently, the known number of diabetics in the world would be about 150 million. That's what we would term as the known diabetics. There's probably a lot more people who are walking around with really high blood sugar that once they get their blood sugar tested, we could possibly fit them into the diabetic category, but it's still quite a really large number of people that are diabetic worldwide. Of those diabetic people, 15% will develop a foot ulcer. So what is a foot ulcer? A foot ulcer is something that starts as something really simple on the foot. Usually it could be a small cut, a small blister, something that you really wouldn't give much attention to normally, but on the diabetic foot, it can progress quickly to something a lot more serious. Many of these foot ulcers will progress to amputation if they're not dealt with appropriately. So people that are self-caring at home thinking, oh, this will be okay, I'll just put a Band-Aid on it, I'll just, put a little Neosporin or something on it, it will heal. It quite often won't heal because on a diabetic foot, we are more prone to infection and things take a little bit longer to heal. So it is quite important to take any injury quite seriously and take it to a health professional, preferably a podiatrist. But if not, if there's no availability at the time, definitely to a general practitioner for them to have a look at. So what podiatrists do is we manage diabetic feet by providing regular foot care on a periodic basis. And we do assessments periodically as well for the progression of diabetic foot disease. So we will have a little bit of a chat about what that entails. So one of the most important parts of a diabetic foot assessment is a very simple test. It's called a monofilament test. And we've got a little diagram up here which shows, and it makes it look sharp and painful, but I'm gonna demonstrate so you can see that it's not. So a monofilament, it's a tiny little thing. You probably can't see it. It's very small. And we press it gently against your skin. What we would do is we would ask you to close your eyes. We'll explain the test to you. And then we'll gently test different sides, the tips of the toes, the balls of the feet. And we might try to trick you by moving it around and testing other sides. What we're looking for is that you register yes with each of these tests. It's a small amount of pressure and it's testing skin sensation and light touch. As long as you have the ability to feel this light touch, then you're at lower risk of having an injury to the foot or one that's going to become problematic. Some patients may say they're already getting some weird sensations in their feet, but when we do the monofilament testing and we go over the sites, they're still recording having good sensation in that area, which is a really good sign. So this is one of the first tests that you will probably come up against when you come to see a podiatrist, and it's one that should be repeated periodically, sometimes 6 monthly, sometimes 12 monthly, really depending. We'll gauge how your foot is going, how your blood sugars are going, how you're managing things, and we'll test as frequently as we think is appropriate. Another test, which is fairly simple, and you'll notice none of these are painful. They're just simple diagnostic tests to give us an idea of what's happening in the feet. There's a simple tuning fork. With the tuning fork, quite often I will start at the patient's knee and I'll vibrate the tuning fork, place it on their knee, and they can all feel quite a firm vibration in the knee. Then we start to move it down the leg, down to the ankle bone. They might still be able to feel it. And then they're often quite surprised that when we press it against the big toe, now we can't feel it the same. So we will go ahead and test different sites on the foot and check what level of vibration you can feel. This is a really important early warning sign. A lot of patients who are going through an episode where their blood sugar is quite high, they might be getting funny sensations in their feet. They might be experiencing a little bit of loss of vibration. And once they get those blood sugar levels down over time, a lot of this can disappear and reverse itself. So it's a really good test to be doing regularly with your patients, regularly with your podiatrist. so that we can sort of gauge how your feet are reacting. Diabetic foot disease is a little bit of a silent disease. It really creeps up on people. So having these simple tests to do along the way is very, very helpful. So what we're testing for in both of these is a condition called peripheral neuropathy. It's quite a big word, but it just means damage to the small nerve fibers in the feet. Now, the damage is when we have high blood sugar, it can be occurring anywhere in the body, but what we're testing is how it's affecting the sensory nerves, the nerves that carry our ability to touch, feel the difference in temperature, to feel pain and to recoil from pain. So when a patient has peripheral neuropathy or sensory neuropathy, they may not be as aware of things that are going to injure them. So they might wear a shoe that's a little bit too tight, or a shoe that has something that's rubbing against them, and they won't notice until there's quite a bad injury happening on the foot. I've had plenty of patients that are renovating at home, or they're walking around barefoot in their home and they've stepped on pieces of glass, all kinds of things, and they've not noticed that it's in there until they come to see me and we find it. So it's one of those, you think you would feel things happening, but sometimes with sensory neuropathy you don't. The other thing that's really affected by sensory neuropathy is temperature perception. So patients will go and maybe put their feet in a foot bath or go for a pedicure and just stick their feet in hot water, not knowing that the temperature is too hot. This is another, thermal injuries are a really common form of an injury for somebody that has peripheral neuropathy, and one that's easily avoided by checking with your hands, not just putting your feet into that hot water. So these are the signs that we can see, but some of the symptoms, a patient might say, I've got a little bit of tingling in my toes or a little bit of numbness. Some patients develop painful neuropathy where they get burning or shooting pains in their feet. And all of this leads to an inability to detect there's some damage occurring to your foot. One of the more common ones that I'm seeing now in the practice is with very hot surfaces outside, very high temperatures. I've had patients walking around in their house slippers, which might have a very thin sole on them, and they might wander outside and stand around outside, talk to the neighbour, and then by the time they come inside, there's a little bit of a thermal burn to the skin surface. They don't notice, they keep pottering around, and by the time they come in, they've got quite a severe thickness burn on their foot. So it can happen very quickly and in very simple surroundings. So something really to be aware of. So another part of the diabetic foot assessment is looking at the blood flow that goes down to the feet. And we use a simple piece of equipment called a Doppler. And what a Doppler does, you can see that in the top of the picture, the Doppler is being held up against the foot. Anywhere where we have arteries or blood flow close to the surface, we can listen to those arteries. So most of us are familiar with going like this to check for a pulse or checking in the wrist, but of course we have pulses in the feet as well. And with the Doppler, we can listen to the pulses in the feet and determine how healthy they are, whether they're giving us that nice boop, boop that you see on all your hospital shows of the heartbeat. So the arteries in the feet are really just a representation of the heartbeat, and the closer they are to what we would expect a heartbeat to sound like, the healthier they are. What happens over time, and it's not just with diabetes, there's lots of other risk factors for arterial disease or reduced blood flow to the feet. But what will happen over time is it seems like best analogy I can give is if you're outside in the garden and you're watering and you get a little kink in the hose and suddenly there's just a little trickle coming out of the hose. If there's not full blood flow or full flow through the artery, there's only a little trickle of blood getting to the feet. And once we have reduced blood flow to the feet, that opens us up to a lot of risk factors. Things won't heal, things become much more easily infected. So it's really important to understand how the blood flow is in a diabetic patient's foot. And this is something we'll also do periodically when you come in for your foot assessment. If we determine using the Doppler that there is quite a serious problem going on, then we'll apply one of these big blue cuffs around the ankle. So just the same as the way you can have your blood pressure taken in your arm, we can take the blood pressure in the lower limbs as well. And what we'll then do is do a comparison from one side to the other. We'll do a comparison with your arm blood pressure. The circulation is usually a lot better in our upper limbs, in our arms. And then we'll get a good idea of what sort of impairment is going on with the circulation to the lower limbs. If there is a need, we will often refer a patient off for a CT scan. So we can refer you on to have imaging done to then visually look at what's going on with the blood flow to the feet and work out exactly what vessels are blocked, and then make an appropriate referral for that to be addressed by your doctor and by a specialist. So another really important part of keeping on top of foot health is knowing your A1C number. A lot of patients come in and they know their blood sugar levels. They took it this morning. It's 130, I hope not. But a number that they're not always aware of is their A1C number. And this is a number that your doctor should be giving you every time you've had your blood screened at the GPs. And your A1C is a much more long-term marker. It's not like your blood sugar test in the morning that tells you it's a bit high because you might have eaten something a little late or had the wrong type of foods in the day before. Your A1C is more of a long-term marker over time. So it gives you a really good indicator of, over the last 2-3 month period, how is my blood sugar in general. An ideal number for that is around 6.5 or below. Anytime it encroaches above 6.5, that means that all those days during that last 2 or 3 months, the body was flooded with a high concentration of sugar, which is having a detrimental effect on small nerves, small blood vessels, and causing complications to occur that we're not even aware of until they become symptomatic. So this is really one of your most important indicators to ask your doctor about. What's my A1C number? And be aware over time that it's staying low or trending down. It's one number that you want to be trending down. You speaking to your doctor about ways to get that under control, whether it be reviewing your medication, a little more exercise, getting a little bit more education with food, whatever that may take, but really important to focus on keeping that number down so that all these complications, including foot health complications, aren't occurring. So diabetic risk categories, and this is something we use in the podiatry profession. We categorise our patients into one of these different risk category groups. So a low risk patient, we've done all the vibration testing, we've done the monofilament testing, and that all tests quite normal. We look at their feet all over and we see there's no calluses, there's no corns, there's no pressure areas, there's no infection risks, something like a fungal toenail or a chronically ingrown toenail. And we've tested them with a Doppler and there's adequate blood flow. So that's a low risk diabetic patient, and lots of our patients fit into this category. Then we have the at-risk patients. There's some loss of sensation, so their vibration perception might not be 100%. They might miss 1 or 2 spots with the monofilament, but none of the other risk factors are there. So we would just keep monitoring those neurological tests to make sure that the filament and the vibration test. Then we have the moderate risk. So these patients have lost sensation. They're not testing well with the monofilament. The vibration tuning fork is not testing well. And we've identified a risk factor there. They might have some heavy callus under the ball of the foot and a really obvious pressure area on the foot, or an infection risk like an ingrown toenail, something that's going to become an ongoing issue with the foot and pose an infection risk. And then we have our high-risk patients. High-risk patients have lost their sensation and they have reduced blood flow to the feet. So what does that mean? That means with a loss of sensation, I can quite easily injure my foot. I probably won't notice. I may not be going to the podiatrist regularly, I would hope so, but I may not be going regularly. And there's reduced blood flow to the foot. Once that happens, that's a perfect storm. That's when a diabetic foot ulcer develops. And depending on how quickly you get to see a podiatrist, an emergency room doctor or a GP, is to how we can then put the treatment plan in motion. So that's a high risk foot, and we do see them, unfortunately, and we're hoping to keep everyone out of that risk category. So what does that risk category mean to you with podiatry care? a low-risk patient, after we've done an initial assessment, we'll probably tell you to come back once a year, once every 6 months, depending on how we identify what your risk factors are with your lifestyle. You might be on your feet all the time in a very active occupation. We probably will say that you can manage your own self-foot care if you are in that low-risk category. If you're at risk, we'll probably ask you to come in more frequently, 6 monthly. And if we identify 1 or 2 things that are a little tricky with self-care, we'll suggest that we take care of it. A moderate risk patient, we should be providing all the foot care at this point, usually at 2 to 3 monthly intervals. And this is the majority of most of the podiatry patients that come in. They've got 1 or 2 little issues that they've tried to self-care with. It's becoming a risk. And we've got a little bit of sensation loss. So it's really not safe to be trying to care for them yourself. And it's really not ideal to be having a pedicurist deal with something that's probably a little outside of their skills and abilities with the instruments that they have, and also with the understanding of the needs of a diabetic foot. It's really not fair to be taking that to a nail salon and expecting them to identify all these things that come up. That's what podiatrists are here for. So if we find ourselves in that high risk category, a podiatrist should be providing all of your foot care. It'll usually be fairly frequent because there's usually issues coming up fairly frequently. And also we'll be referring you for further testing and treatment as required. Some of the other referrals, all of us podiatrists are closely linked to the wound care team at the hospital. And once we identify that there's a foot wound or something that really needs attention, we'll send you to the wound care team at the hospital. And they take care of, in a team approach with all the doctors involved at the hospital, communicating with us. And we make sure that everything progresses nicely without becoming a huge problem for the foot. So these are some of the examples. This is a good example here of a pretty at-risk foot. If you look at the toenails, they're all curly and curved around and they look kind of tricky to cut. You can see the toes are retracted back and there's a lot of pressure on that ball of the foot, which is giving that patient a lot of callus, a lot of pressure on that area. So this is the type of foot that would have to be coming to see us on a pretty frequent basis. You don't want to be taking one of those callus files and trying to file away at that callus. That's going to create possible friction and an injury to the area. And that's something a podiatrist can easily remove very quickly within one visit. And especially those, you can tell that's kind of a really high arch foot. There's a lot of pressure occurring there. Even the tips of the toes, and we've got callus on the tips of the toes, under the big toes. So that's the type of issue that needs to be dealt with on an ongoing basis by the podiatrist, preferably not by a pedicurist who isn't aware of the underlying health issues. One of the other friction issues is a blister. So friction is anytime we've got rubbing occurring either from our footwear. Friction can occur by using one of those things that removes callus, like a pumice stone. I've seen plenty of patients injure themselves using a pumice stone, so that's something you want to avoid. But a blister can very quickly develop, especially somewhere here on the back of the foot where there isn't a lot of tissue. It's a really thin amount of tissue between the outside world and the bone. So a very simple blister occurring on the back of the heel can quickly progress in a diabetic foot to something a lot more sinister. So a simple blister needs to come in and see the podiatrist so we can assess if there's damage underneath that and how is the best way to deal with it. We'll also we'll also make sure you bring the shoe in with you so that we can see how did it happen and make sure that won't happen again with that footwear. Something else, and I apologise if anyone's eating lunch, but I just had to include some photos in here. One of the more frequent issues is dry cracked heels. And we would think, how is this a risk? You can see at the depth of those cracks, that's going to turn into a risk pretty quickly. Again, this would be something that someone would probably want to self-treat. I've had patients attack these with a vegetable peeler. I've had patients try to remove this type of callus with all kinds of things, and it's not safe. So coming into the podiatrist, we will very safely remove the dry callus and use a very soft sanding machine, get that skin back to as healthy its condition that we can. One of the things that's really important then is to be using a product that's going to draw those cracks together and not let them go deeper into the skin. And as I've put up on my slide, you'll find there's creams out there that are usually called for dry cracked heels. They're available over the counter in the pharmacist. But one of the products they need to contain is 10 to 20% urea, and urea is a product that's going to draw those cracks together. Just using our basic body lotion isn't going to be enough for this type of situation. So once that area is being dealt with by a podiatrist, some good maintenance at home with a good quality urea product is going to keep that foot from developing into that sort of crisis point again. And again, this is another example of if this occurs on a diabetic foot, it has to be seen fairly quickly before it develops. Now, I used a cartoon for this one, for those people that are definitely eating lunch. One of the very common issues that comes in to see us is an ingrown toenail. A diabetic with an ingrown toenail, or a toenail that curves and grows into the sides of the nail. This is something that needs to be taken care of, obviously on an ongoing basis, every 4 to 6 to 8 weeks, depending on how fast the nail grows. Self-care of this type of situation can get you into trouble really quickly. Again, there's not a lot of tissue between the outside world and the inside of the toe. So if an ingrown toenail gets infected, the infection can pass into the connective tissue quickly. It can pass into the bone of the toe pretty quickly. And then we've got a condition called osteomyelitis happening throughout the foot. And that's something we would then have to get some IV antibiotics, and it can progress very quickly. So given that a diabetic foot can get an infection very quickly and takes longer to heal, this type of situation can be a real red flag emergency for a podiatrist. So initially, if we have a diabetic patient come to us and they do have an ingrown toenail, a chronic ingrown toenail, and they've been either trying to self-care or going to a pedicurist or a nail salon to have it dealt with, not fair on the pedicurist to be dealing with this kind of high-risk situation. We will start by doing conservative management. So we will bring you in every 6 to 8 weeks. We'll clear it completely and painlessly and keep on top of it. If for some reason something happens and the nail gets out of control, either you tried some self-care or you're away traveling and didn't get to us in time and it becomes inflamed, the toe can blow up into a really infected, painful situation. That's when we might suggest we now need to move to a more permanent solution. And podiatrists will offer a permanent solution that's called a wedge resection, where we would take a portion of that toenail out permanently, and that's done under a local anaesthetic. Once that portion of nail is taken out, we use something to cauterize the nail bed so it no longer regrows. So we're not taking the entire nail off, we're just taking the portion of nail off that's growing in and causing problems for you. And once that's healed up, now you've got a toenail that's much easier to care for. It's not flaring up regularly. It's a long-term permanent solution to this. So that is a big issue that pops up for us a lot, and two ways that we will deal with it in a diabetic patient. Again, toenails. Toenails can become fungal, and this is something we see a lot in Bermuda. The reason for that is our humidity. We have such a humid environment. We might dry our body off with a towel, but we're not really dry. Especially in the summer months, there's still moisture hanging in on our skin, around the nail folds, around the toenail. So one of the things that we will do is assess for fungal toenails. And if you do have a chronic fungal toenail, that's a risk factor that we need to be bringing you in more frequently for. There are ways to deal with a fungal toenail if we see it in the early stages. Unfortunately, most people bring a fungal toenail to us that's quite progressed, like the toenail that we see here on the right-hand side. One of the early stages is when you see little white clouds appearing in the nail that look like little white powdery surfaces. And that's an early stage. We can definitely deal with that. We can also deal with a toenail that has a small portion of fungal involvement, but the minute it takes over the whole toenail, now we're looking at a much more complex issue. It's been there for a long time. It's probably involving the nail bed underneath the toe. So this is even a thickened toenail can look like this. It may not be fungal, but it's still going to cause a problem for a diabetic patient, especially if we're wearing footwear. One of the things I have to bring up when we talk about fungal toenails is nail polish. It's one of our favourite things to do is paint our toenails, especially in summer. But when we consider that after our shower, moisture gets trapped around our toenails and under our toenails, we add nail polish into the mix. Now we're just trapping in all that moisture and trapping in any little fungal spores that may be around in our environment. We might leave our toenail polish on for a month, which is a terrible idea. We take it off and suddenly underneath the toenails change colour. So I always urge caution with nail polish, especially with my diabetic patients, but with all my lady patients. Definitely limit your use of nail polish, especially in the humidity of summer. If you have it on, put it on for 2 weeks and then remove it and check the toenail, check that it's healthy, check there's no colour change, buff the toenail out and then reapply. But definitely do not keep painting over. Do not keep it on for longer than 2 weeks at a time, because there's more likely to be a problem underneath when you do. And one of the safety precautions I always say to my patients, whether we have a fungal toenail or not, or whether we have nail polish on or not, one way to dry around our toenails after every shower is to get rubbing alcohol, put it into a spray bottle and keep it in our bathroom. And after we've dried our feet meticulously between every toe and around our toenails as best we can, we give them a nice spray with rubbing alcohol. And think of it as like deodorant for your toes. It dries the area, around the nail and underneath the nail, and it limits the chance of a fungal infection taking hold in the toenail. This works really well for fungal infections between the toes as well. A lot of people, especially people that work in heavy boots or work in the same sort of footwear for long hours, people in the service industry, they're more prone to fungal infections between the toes. And the use of rubbing alcohol after every shower to keep a nice dry environment is a really good way to stay on top of that and stop it from progressing to a much bigger issue. So, safe self-foot care. This is something a diabetic needs to do every day. Washing thoroughly, especially between the toes. It's amazing how often we don't wash between the toes, and it's a really important thing to be doing. Drying thoroughly, especially between the toes, and again spraying the rubbing alcohol. A diabetic should inspect their feet every day. So people will often say, well, I can't see underneath my feet, I can't, how can I inspect? If you can't have someone assist you with that, you can use a mirror. So a lot of my patients will use a mirror to inspect underneath their feet, in the areas behind the heel where they can't really see. So a visual inspection is a really important thing to do every day. The applying lotion is really important. All those nasty, dry, cracked feet that we saw before, if we're applying lotion every day, the skin stays in better condition. It's not as likely to break down or become problematic, but we never apply lotion between the toes. That would kind of create a much more moist environment, and in a humid environment like Bermuda, we don't want to be adding to that. So keeping it very dry between the toes is very important. Footwear is another really important part of a diabetic foot assessment. So I will always tell my patients, bring your footwear to the appointment with you. I don't want to see your favourite shoes or the shoes you're wearing to impress me because they're cute or they're new. I want to see the shoes that you wear all day, the ones that you wear at work, the ones you wear for working out in. If you bring those to your podiatry appointments and we need to do something temporarily, like we found a pressure area under your foot and we need to offload that area, we can do something right there and then in that shoe if we bring it to the appointment with you. So it's really important that we have access to the shoes that you wear most frequently. New shoes, when you buy a new shoe and you're first going to wear it, it's probably a good idea to check inside with your hand, not be just putting your foot in and walking around, and if your feet don't have good sensation, then finding out later that they caused a blister or they have a seam inside that's rubbing and it's going to cause an issue for your foot. It's quite important to check regularly during the wearing in process. So for the first week or so, taking the shoe off, looking for red irritation areas on the feet, looking for wearing, abnormal wearing inside the shoe where your foot's rubbing against it. Really important to do that. And really being barefoot, as much as we enjoy it, if we've got a moderate risk foot or a high risk foot, we should really avoid being barefoot at all costs. Even if we're inspecting, the issues can happen too quickly. So just concluding my presentation, just to get in touch with me if you wanted to ask any more questions. My website is up there, archerspodiatry.com. My email is reception@archerspodiatry.com. My physical location is Cedar Avenue, which is #1, right down next to the tennis stadium. And to get in touch by phone, just to let you know, I don't have a receptionist. I'm kind of a one-woman show. So please leave me a message. I will get back to it, but it's much easier to get in touch with me by my website or by my email address.
Thank you so much, Dr. Bennett.
Thank you.
I think the information that you have provided has been very helpful to the listening audience. I will give everyone a few minutes. If you have any questions for Dr. Bennett, please submit them in the comment section of our Facebook page or of this feed, and we can get those addressed. If not, we will conclude today's webinar presentation. Dr. Bennett, do you have anything else you'd like to add?
I would probably, one thing to add would be reaching out to the other resources that are available. So obviously Bermuda Health Council has a lot of good health information on their website. I know you had one talk about nutrition recently. So there's lots of good resources. Also, Bermuda Diabetes Association is another really important resource for diabetics. They have their own on-site pharmacy. They have a lot of information there about diabetes in general. They do a lot of education with regards to diet, safe exercise programs, pretty much one-stop shop for diabetes care. So hopping into the Diabetes Association is another great place to get some support and some good resources.
Wonderful. We do have a question that just was submitted in. It's from Ms. Wellman. She wants to know, how can a diabetic person best protect their feet in the summertime? Because I know we love to wear open-toe shoes. So what is the best way to protect our feet?
Sure. So going back to the safe self-care, I would say making sure that the feet are clean and dry after every shower, making sure we're drying thoroughly to avoid fungal infections. So using the spray, rubbing alcohol, using a lotion. And I generally say to patients, don't put lotion on in the morning. That's going to make your feet slippery and sweaty, especially in the summer months. So putting in the mornings, making sure we use rubbing alcohol before we go out during the day, and then making sure we apply a lotion and inspecting the feet every evening. So doing that visual inspection, and the process of putting lotion on puts you in touch with your foot. You'll feel if there's something a little not right, something a little rough under there, something might be poking out of your foot that you haven't felt. So that inspection, trying to wear shoes, flip-flops or shoes, especially when you're going to be on hot surfaces, really important. And finding a flip-flop that doesn't rub or irritate, something that holds onto the foot quite well, probably not your average thin house slides or flip-flops, something with a little bit of cushioning under the foot.
That was a wonderful question. Yes. I do also am quite curious to know, I know that there's some people that detox their feet at the end of the week, just doing a little up and saw and hot water spa treatment. Is
Mhm.
that helpful, or are there any other measures that we can take to maintain our health?
So when we're talking diabetic or the general public here, with a diabetic, I'm not a huge fan of foot soaks only because they compound fungal issues. They, especially in the humid weather, they're going to increase the moisture content around the toenails. So soaking, I would keep it to a very short period of time. I wouldn't keep my feet in there for a long time. And the temperature of the water is something you always have to check. So again, for a diabetic who may have some sensory loss with their feet, check the water with your hand, both hands, you know, just to make sure the temperature is not too high. And just, I know there's a lot of those detox products on the market where you wrap your feet in them and sleep in them. And I would urge
it's quite
diabetics
concerning.
not,
Yeah.
I would urge a diabetic not to use those.
Okay.
I don't know enough about them to have an opinion about them for the general public. Hey, if it feels good and it's not harmful and you've tested a patch on the skin, go for it. But for my diabetics, I would say no to those. Yeah, let's stick to the basics with what we know is safe for a diabetic foot.
Yes. Thank you so much, Dr. Bennett. That was very helpful. I think we are okay with questions for now. The general population, you're more than welcome to send Dr. Bennett a question via email or give her a call as listed here on the screen. If you have any further questions about our Health Council webinar series, you're more than welcome to reach out to us here at the council at 292-6420, or you can email us at healthcouncil@bhec.bm. Again, we have another webinar event next week, Wednesday, same time, right here on Facebook. The topic will be on the introduction to breathing. We're excited to cover a variety of topics for this series. So please feel free to reach out to us. Thank you again, Dr. Bennett. Please, everyone, enjoy the rest of your day.
Thanks.